Thank you very much. Well, it's a pleasure for me to be part of the program, and it's the first time that I'm joining Rayos Contra Cancer as a lecturer, which is great. So as Kathy said, my name is Cesar Della Biancia, and I'm a physicist at Memorial Sloan Kettering in New York. And today we are going to be talking about contouring for medical physics. So basically, this is going to be the outline of the presentation. I mean, the first three items, I'm going to go a little quicker because, it's things that we all know already, but I wanted to point out very special on each of the topics, and we're going to concentrate more on the last topic, which is the main topic of the presentation, which is contouring for IMRT and VMAT planning. So starting with general guidelines for contouring, for any type of plans, that especially for IMRT and VMAT, if you delineate accurately the targets and the order, this is a very critical step in the process, especially for IMRT and VMAT, because most of these contours or contours made from these contours, they're going to be used on the inverse treatment planning algorithm. So if you start with bad contours, you know that you're not going to get good plans. So that's what I don't want to say it's the most important step in the planning process, but you need to pay really close attention in contouring. So in general, for example, for ORs, I can separate in two categories, like perfect ORs, meaning like very good contours. For sure, are contours meant to be when they're close to the targets. Imperfect can be okay when it's farther away. I don't want to say that you need to do imperfect contours. That's not my message. The contours should always be very nice or close to perfect. But for example, if you can see there, you're going to pay more attention on a proximal bowel for an SBRT pelvis case, because you know that that's going to be the organ at risk for that type of plan, than for, is the bowel cases that the bowel is farther away. So you don't waste too much time on less important OR in terms of clinical efficiency. But again, the message is not, that's what I put imperfect with quotes, because we don't want imperfect contours in general. So we want to have good contours, but it is okay if it's farther away and it's not going to affect your plan. So, if you're used to be planning for 3D, like a 3D conformal radiation therapy, you will notice that now when you start doing IMRT and VMAT, and because of the inverse treatment planning algorithm that you need to use, you're going to be contouring a lot more structures, especially in the vicinity of the PTV, than you used to do for 3D. So this is important because you need to kind of advise or help the optimization algorithm as to whether or not it's okay to deposit some high doses in some particular reason. So that's what is very important. The contouring is more important in IMRT or VMAT than a 3D plan. A 3D plan, you define the fields. Of course, you contour things around, but IMRT, you're going to be using those contours in your optimization process. And there is a lot of additional structures besides the targets and the OR that you're going to be using only for optimization. And these are what we're calling here the medical physics contour. That's what the purpose of this talk. So we're gonna talk a lot about that and what are the ones that we're gonna be following for our method of planning IMRT. So basically, by defining the intersection of targets and normal tissues as separate structures, so different prescription doses and constraints can be easily be applied to different regions. And this is, you're gonna make sure that you're gonna facilitate the control dose gradient between the normal tissues and the target. It's very important when you're in your institution, when you're implemented a new IMRT program, to recognize that you're going to be spending, not only physicists, but all the physicians, they're going to be spending more times in contour than you were used to do it in 3D. One reason for this is, as I said before, because you need to define a lot of these optimization-only contours. And there is sometimes they're going to be high doses that you're not gonna want high doses to encounter normal tissues during the optimization. So the only way to lower the dose to this structure is to contour them and to place those constraints during your optimization process. And here's just an example. I mean, we're going to go through a lot of pictures and example. Like this is a head and neck case. As you can see, you have your target. The yellow is the yellow and the red are the PTVs. You can see the parodies, the right and the left, and the core. As you can see here, the left parotid overlaps with the PTV. So this is the structure you're going to be taking more caution when you're contouring. And for example, and we're going to go through many ways, because again, different institutions or different planners have different way to plan IMRT or VMAT, but you can create this extra structure. For example, in this case, I created the parotid. The left parotid is the green, the whole thing. And then I created this parotid not PTV with some margin from the PTV, just because I'm going to use that for my optimization to control the mean dose, which is the constraint that we use for parotids. But again, this is just a quick example. Then, of course, you have the core. The core is a very critical organ. So we might be creating extended or expansion structures around the core just to control the high doses close to those structures. But we'll go that through later. But I just wanted to make an example of what are we going to be talking about. In general, I mean, I don't know, in most of the countries and many places, people will follow contouring atlases, and there are many in the literature, or I'm sure in your own countries you have some atlas suggestions that you might follow, your physicians will follow. But if not, I mean, here in the United States, there is a good resource done by the RTOG Foundation. And if you go to this website, which I put here, you will go to this window, and then you will access to the contouring atlases here. And then this window will pop up. And then you can see here that you have the different anatomical sites. And then if you go to, let's say, lung, you're gonna have the atlases for all the structures that needs to be contoured for that particular anatomical site. Like how do you contour the heart? How do you contour the lungs and so forth, like brachial plexus, whatever is important in that area. This is just an idea. So just want to emphasize that the use of atlases is good because that actually makes things a little more standard, and we all do kind of the same thing. Another point that I want to go quickly again is, and this is important actually in our institution, we discovered that it's important just to standardize the name of the contours, like the nomenclature, how we call things. So, and that actually creates it makes the clinic more uniform and transparent. I mean, if you need to share information between your colleagues, so you're going to be talking about the same things instead of ambiguity. So we have in 2018, the APM released this report, the task group 263. And this report actually was basically done with some, just to make sure, to provide nomenclature guidelines in radiation oncology in general for using clinical trials, data pooling initiatives, population-based studies, and routine clinical care. So basically, this is done because especially when you start collaborating with other groups or you go to research, I mean, and you send information back and forth, it's easy if we kind of use the same names. So I'm not going to go through a lot of detail, but basically how they basically wanted to create this report is because they did some surveys in many institutions, and they found out, for example, just to give you an example, the variations on the naming that they found between 16 institutions, for example, for the left optic nerve, 12 institutions replied, and you can see how the optic nerves are being called by many of the people. I mean, you can get it. I mean, but for example, if you just have ON_L, I mean, yes, you might know that it's the optic nerve _L, but sometimes it can be ambiguous. And you can see the big difference, I mean, the big variety, basically. Same thing for the lungs and stuff like that. And also for the targets actually, they have a huge guidelines of how to name targets as well. And again, it was a survey done by 12 institutions, and there was some ambiguity or maybe differences between the way that you call certain targets. And then this is, I mean, I just put some parts of this report. Actually, this report can get, you can access through the APM. This is the website. And I know that most of the countries you can, if you participate in the Partners in Physics, I mean, you can get access to that. This is a free, let's say, no membership, but affiliation to the APM, and you can get reports. But anyway, I have a copy, so I'm gonna probably send it to the host of the Rayos Contra Cancer, and then we can share that. But just here, just to, again, the report is very extent, but for example, it tells you how to, for example, how to the laterality. I mean, instead of writing the word left, which takes a space, normally they will use the letter L. R for right, A for anterior, or for example, for things in the lung, RUL means right upper low, and then so on. And then, for example, if you're talking about, let's say, arteries, if you're contouring like the aorta, so you will, they suggest to say, okay, for arteries, let's put an A in at the beginning, underscore the name of the artery. And if it's a vein, you would put a V and then underscore and the name of the vein. One thing that I want to point in item number 15 is also for these optimization only structures that I name. They suggest, and again, this is a suggestion, to add a Z at the beginning of these structures. And there is two purposes for that. I mean, we have adopted in our clinic, and it's actually very useful because most of the treatment planning system, they list the ORs or your structures alphabetically. So it will be nice to have alphabetically all the structures that the ORs and the target that you're going to be evaluating, and then structures that we as medical physicists come to that they don't need to be evaluated on the DBH, but we're going to use it on the optimization. They will show it at the very end. So they're all going to be at the end. So that's actually a nice thing. I mean, just to organize your structure sets. Same thing for the targets. They have advice how to name things on the target. Again, you can read this in detail. I don't want to go too much into this, but it's a very good document if you're interested to follow, or maybe you do have already a nomenclature standards in your respective countries. So the next topic that I want to go through quickly is about image registration that we use for contours. Normally, I mean, the CT scan is what we use for planning, but it's very often that the physicians would like to use MRIs or PET scan just to delineate targets and normal tissues or ORs, because they're you can see them better. You can see the boundaries very better between targets and certain ORs and stuff like that. So in general, and again, I don't know, many institutes, they have different, it varies a little bit. In general, it's the planner who's going to be doing the image registration, and the medical residents or attendants will, and in other institutions, the medical resident or the attendants will perform the registration. It depends. For example, in our institution, medical physics does the registration, and then if the physician doesn't agree, that's what here is very important, to empower your doctor to make sure they know how to tweak the registration in order to make slight modification. Because imagine, this is going to be very important to accurately delineate the targets and the normal tissue. Also, it's very important to get proper guidance from your doctor if you're doing the image registration. It's not only sufficient to say, okay, fuse MRI from this day and sequence to the CT from this day. That's not sufficient. I mean, it's good data, but also, like, for example, they should be telling you to focus on something. For example, fuse this MRI to this CT focusing on the spine, because I know that my targets are going to be around the spine. And that's very important, because especially when you go through, I don't know, in many institutions, maybe you have an MR scanner dedicated to your practice, but maybe not. So the planning CT is going to be done using all the immobilization device, so the patient is going to be in treatment position. But sometimes the MRI or the PETs, they're going to be done before. There can be diagnostic MRI and PET, and the patient is not going to be in the treatment position. So, for example, for a lung, maybe you're simulated the patient with the arms up, and then the MRI or the PETs that you're going to be using for fusion, the arms as down. So there are going to be some differences. So it's very important that the physician tell you where to focus on. And also, if you're doing any deformable registration, make sure that you are very conscious that because deformity can be tricky. So, and there are very easy ways to verify the deformable registration using small structure defined by border, where the anatomy doesn't move much. For example, the brain, the head and neck cases, or mediastinum. But for example, for pelvis cases that organs move, or the boundaries of the edges are not very well defined between one study and another, it can be a little tricky. So you have to be very careful when you are doing the formable. Here, this is just a little video that I have. You can see it's a brain, and you can see how the CT, you can be focuses on the ventricle or in the brain and the fissures, just to make sure that and then you should look at all the coronal and the sagittal, because you want to make sure there is no rotations, and of course the translation, but you want to make sure that it is good. Here sorry, that's good. I have another example for another brain case that you can see. For example, you can focus here on this is a CT, this is the MR, on the ventricle, using all these features. You can see the pineal glands, actually, that's very useful. And again, there are different ways and different tools how to check this fusion, but you have to develop the one that you are more comfortable with. Okay, so that's about fusions. And then, of course, the physicians, they will give you the contours, most of especially the targets and the most critical ORs. So, and most of them, they will follow these protocols or atlases to delineate the targets and normal tissues. And there is many auto segmentation tools in the market now. On some treatment planning system, they do have it, but it's a very useful tool. But you need to be careful, because you can lead to the overconfidence. Maybe you just trust the auto contours, and then you don't even bother to go and check what the auto segmentation did. Most of the time, they do a good job, but it's very important to carefully inspect the contours delineated by physician, especially when there are normal tissues adjacent to the targets, because this will make a big difference during the process, the planning process, and the dose evaluation. This is basically, just like a suggestion. It's very important to make sure that you have good contours, because now that we're going to the really topic of this talk about the contours that we need for IMRT and VMAT planning, if you start with bad contours, and we're going to be creating optimization only contours from this, then you really need to make sure that they're good. So these additional structures that we only use for optimization, that we are calling optimization only contours, these are what the planner will define, and we call them medical physics contour, if you want. So sometimes it can be defining the intersection of targets and normal tissues as separate structures that can help to control dose gradient between that normal tissue and the target. And also, as I insist before, again, suggestion is just to make sure that you have a naming convention. As I said before, remember from the DG63, from the APM article, they suggest to call this structure with a Z at the beginning. So again, this is something that you can take or not, but it actually makes your list of contour much more, visually readable. We have actually, and that's something that I'm going to send you guys, we have a VMAT planning guidelines document where you have a lot of, you have about a part that is all about the contours and then all about the planning itself, planning process itself. And then it's very important, the planning process is the next topic 17, next Monday, I think. So we're going to go through that, but I'm going to give you that document. But basically, we're going to be using the knowledge of theoretical dose fall-off to accurately predict where the dose should be if pushed properly. So if this is done correctly, we can create contours such that the optimization algorithm functions as efficiently as possible. We want to predict exactly where the PTV will be covered so that the optimization algorithm will have no problem covering the expected PTV contours completely. And again, different institutions or studies that you're doing within the institution may require slightly different dose criteria for PTVs. And so you have to also follow what your dose constraint and prescription, especially for PTVs, that you follow in your institution. But here we're going to try to make it a little general. So in general, for ORs, we said that we always want to contour ORs with margins. For example, here you can see this brain. It's a brain case. The target is the pink volume here. And we have created expanded structures around, for example, the brainstem, which is in orange. We created an expanded structure with 3 millimeter margin around the brainstem, which is in magenta color. They include a margin to ensure that there is no high dose adjacent to the structure itself. So you can see here how close is the PTV to the brainstem. You want to make sure, because you're going to try to give as much dose you want to the PTV, and then you want to make sure that there is no high doses very close to the OR. That's how we create that as a buffer. See here on the next picture on the right, you can see how we did the same for the cochleas. Here also we did it for the optic nerve, for the eyes and the chiasm, but these structures are overlapping with the target, and we have other structure that we will create. But normally we will create margins of all the ORs, like 3 millimeters the usual. We said for core, normally we say 5 as a PRV, but that we'll talk a little later. The guidelines, what I was saying that we're going to be using to create Contra is using this dose fall-offs concept. And there are two different dose fall-offs. I mean, so the maximum fall-off of dose confined to a small volume in general is about 10% per millimeter. That is the dose fall-off near, for example, the brainstem, the parotid, the spinal cord, the rectum. So the 50% isodose line will come within 5 to 6 millimeters away from the edge of the PTV, which should also be covered by 95%. So you need to have that in mind. So you want to cover your PTV by 95%, but also you need to make sure you know that by this dose fall-off, 5 to 6 millimeter, you're going to have supposedly the 50% isodose line. There are other things to be considered. We look when we are talking about the planning. The other concept is that the average dose fall-offs around a structure should be about 5 millimeters 5% per millimeter. For example, if you create this ring, which I'm going to tell you in a little bit what is that ring mean, which is basically like a band or like a ring around the PTV. A ring of 3 millimeters away from the PTV should have a maximum dose of 85% of the prescription dose, because if you think about it, that is 5 millimeters, the dose fall-off is 5% per millimeter, so you have a 15% fall-off. So the max dose that you're going to put on that ring, which is 3 millimeters away, it should be 85%. And of course, the rate of the fall-off decreases with the distance away from the target. When you have multiple PTVs, this is when you have, for example, for head and neck plans or pelvis plan, then the DVH will fall off to a maximum sharply for both PTVs in the optimization, with the optimization for a max dose, let's say, of 1 or 5%, more or less. So the formula to calculate the margin between those two PTVs, it will be done, is there, which is, I have an example here. For example, the PTV inside another PTV must be separated. We want to use the 5% per millimeter criteria, those fell off. So let's say if it's a PTV 70 inside of a PTV 5940, the expansion that I need to, when I separate the targets, is it has to be a 3 millimeter, because if you plug the numbers here, 59.4 divided by 70, 1 minus that, times 100 divided 5, which is the 5% per millimeter, it will give you roughly 3 millimeters. So, and again, we're going to go through this in more detail when I tell you examples of the contours, but just for you to keep in mind that these are very important concepts. The most common optimization-only structures are listed here. So we're going to have a lot of planning target volumes, meaning volumes or optimization-only structure that they're going to be helping the target volumes to get the dose that we want. We're going to be creating rings, which is these bands around the structures, normally around the PTV. We're going to be creating rinds, which is, I know that this can be messed because, for example, in our institution, we call rings rinds, and some people, they have different names, but I want to make sure that this is kind of what everybody does. Rinds is actually basically rings inside the PTV, and I'll tell you later how we're going to be using those. Then you can have OR contours, which we went a little bit with some margins, and then OR helping structures or extra structures that we call sometimes dummy, like maybe you need to focus on a little area, and then overlapping PTV and normal tissue, so that some structures, when they're overlapping, how we take care of that. So again, we're going to start with the planning target volumes. Again, these are all structures that are going to be helping you when you're optimizing to make sure that your target gets the dose that is being prescribed as much as possible. With, thinking that you also need to protect the ORs that they are in the vicinity of the PTV. So most of the time you're going to be subtracting this, we're going to be creating this VMAT PTV, which we subtract out the overlap margin of each OR that must be spared, following the principle of 5 to 10 millimeters percent per millimeter of those sparing near the OR. So basically, and I'll show you an example and a picture in a little bit. So you're basically going to be creating a PTV that you're going to be using for optimization, which is going to exclude with the margin the OR that is overlapping. For example, in a head and neck case, the optics, the brainstem, the spinal cord, doses might be spared, the MAC doses might be spared, and also we also have structures like cochleas and parotid where the mean dose needs to be spared for these cases. So assuming, for example, like a 7% per millimeter dose for loss, for example, for a brain case, or the target going to 60 gray. So you're going to have the if the brainstem, the optic nerve, in this case, right, because I have an example to show you, and the chiasm are overlapping with the PTV, and we know the maximum dose for those structures is 54. Maybe for the brainstem it's a little more, but just to make it simple. The margin that should be subtracted from the PTV 60 to create the VMAT PTV 60 will be applying the formula, and that will give you, if you apply, this is like 1.4, almost 1.5. So you can use, you can be a little more generous too. You don't need to use the value that it says there. So between 1.5 millimeter and 2 millimeter of margin of the brainstem, optic nerve right, and the chiasm, in order to completely cover the VMAT PTV 60 and sparing those OR. And here is the example. So here you can see how the PTV is the red. This is the PTV that is I want and the physician wants to get 60 gray. But then, of course, you have these overlapping structures. Here, the chiasm is in blue. The brainstem is in orange. And then we created the expanded structure by I put 2 millimeter here because we said if you do the formula, you can see that it's 1.4, we use 2. And then we're gonna create the VMAT PTV60 is gonna exclude those structure with that margin. You can see here how the optic nerve is overlapping with the PTV, and there is in yellow is the margin, the 2 millimeter margin. So you can see how we created this VMAT PTV60, which is in the cyan color, to be used for optimization. So these structures, what the main concept is that you're going to be using just to help the optimization algorithm not to get confused, because if I tell the algorithm, okay, I want 60 everywhere here, but also I want to lower the dose here to 54, it's going to be competing. So we're going to create this, and then we're going to use other techniques to, to start lowering these as much as we can without compromising the PTV coverage. There are other structures that we also create to help the PTV coverage, which is margins. We call them margin subtractions, and is for structures ORs that the mean dose is the tolerant dose, like in the example that I told you for head and neck, like the cochlea or the parotids. Again, for this, it's a little more involved, and again, in that document is you have very, very well detailed how to create, and I didn't want to take too much time here. So, so basically the trick here, we're going to be creating multiple VMAT PTVs. So the VMAT PTV that I explained before, we're going to be creating multiple of those, like PTV, VBOR3, and so forth, which they're going to be shells of constant thickness, let's say 2 millimeter, with subsequently graded margin from the ORs of interest, like for example, 0, you're going to start with 0, 2 millimeter, 4 millimeters. So basically you're going to create this VMAT PTV with like first with no margin, then with 2 millimeter margin, 4 millimeter margin, 6 millimeter margin of that OR. So the VMAT PTV created, is going to be the VMAT minus the sum of all this VMAT. And then during the optimization, you're going to start putting a lower limit in all the PTVs, the VMAT PTV and all the PTV, the VMAT PTV ORs with equal weighting. Then you're going to start watching. If the OR mean dose is not achieved, is still high of the desired constraint, you can quickly delete the VMAT PTV OR1, which was, let's say, the closest to the OR. So you delete that because we know that we're causing, it's not helping us to lower the parotid mean dose, in this case, if it's the parotid. So you're going to delete that, then you're going to be using the 2 millimeter shell. And so you're going to be trying to optimize on that and removing the ones that they're not being effective. And you're going to be continuing this until the desired PTV full coverage is maintained. So you always have to watch that your PTV is still well covered and the OR mean dose is achieved. So basically you stop right there. So maybe you stop on the OR with 2 millimeter margin, or maybe there was too much overlap and you needed to use the 4 millimeter margin. So you're going to be seeing that while you're optimizing. But these are very useful structures. Another structure that we were going to be using is a max PTV structure of each PTV. So in general, when we are optimizing, we anticipate that the algorithm will have difficulty limiting the hotspots higher than the desired through the lower, not the lower, dose PTV, high dose PTV when there is no overlap or zero margin between those two PTV. This is for multiple PTVs. So the structure will be the lower PTV, the lower dose PTV subtracting the higher dose PTV with a margin. We talk a little bit about this. For example, this is the formula, and the denominator here is follows the guideline of the dose fall off of 5% per millimeter, focusing on that structure. For example, in this pelvic case that we have a PTV in magenta, actually, you see the color here. So the PTV 45 is all these. Then you have a PTV 54, which you're going to be boosting is the Zion. So we're going to be creating, if we do the formula, we're going to come out with a margin of 3.3. I use 3% here to create 3.3 millimeter. I use 3 millimeters. So you're going to be creating that Z max PTV 45 by subtracting the PTB 45 minus the PTB 54 plus this 3 millimeter margin. So that will help the algorithm not to, because here I want 54 gray. Here I want 45. So you're giving a little buffer and helping the algorithm not with the maximum doses, especially on the lower dose, because you know that here is going to be more than, just because you want to cover 54, the maximum doses in this region is going to be higher. So you don't want to confuse the algorithm when you give the constraint, the objectives to the lower PTV. By creating these structures, we can limit the high dose to only the regions where dose is expecting to escalate near the higher dose PTV. And we can easily use the optimization algorithm to contain hotspot within the rest of the lower PTVs without putting a stress on the algorithm by using competing optimization objectives. Another structure that we're going to be using is these edge contours for each PTV, which basically these edge contours are like 5 millimeter lines or bands inside at the edge of each PTV, inside the PTV. And I show you an example. Because we, in general, when we start optimizing, we anticipate that the algorithm will have a little difficulty at the edges of the PTV. Why? Because you're trying to have the PTV coverage, let's say, by 60 gray, and then suddenly outside the PTV, you say, I don't want those everywhere else. So the algorithm get a little confused at the very edge of the PTV because it's trying to lower match, and then you're going to be ruining the coverage there, because you're also telling if you're using, or if you're constraining OR, or you're using normal tissue optimization NTO, which is for the rest of the body, not the PTV, then you might lose the coverage in that boundary. That's why we create these small structures. And I have an example here on a brain case where the PTV is in red. I mean, it's all the shadows of it. The PTV basically is all these. This is all red. Unfortunately, it's hard to play with the colors here, but that's the PTV, is the whole thing. Then you have the brain stem, you have the chiasm and the optic nerve. And remember, we created before this VMAT PTV 60, which is excluding the OR with some margin, so which is the magenta, the cyan here, the cyan color. So we're going to create this ring or band inside of 5 millimeter margin inside the PTV VMAT, the VMAT PTV 60. And that's what we're going to call Z Edge PTV 60. And that's the structure in blue, because we're gonna given special objectives to that structure. Basically, we're gonna be forcing, okay, don't lose coverage here. I want you to focus on that area. Of course, everything else is important, but in this area, because NTO is gonna be decreasing the dose right away, so we want that for help. Also, we have corners structures that we create for the PTV, because in general, we anticipate that the algorithm will have difficulty when there are sharp corners on the PTV. For example, when you're on the tips of the nodal chains in pelvic cases, of head and neck cases. So we're going to be creating these small volumes on the PTV, so the algorithm can focus on that area more efficiently. So for any PTV with sharp corners, you're going to copy and paste that VMAT PTV that we created before. And using just the eraser, you can erase away all of the PTV except the small area, which can be 2 centimeters, just included the corners. And I have an example here. So for example, for this pelvic case that we have, this is what I meant with corners. So just because of the shape and the, here we have bowels. So the algorithm, it always will have issues to cover this area. It will be easy to cover all of here, but not that much here. So these are the areas that we create corners PTV. And again, we create them, but because we're going to put a special attention on that in those structures. Then this is also something, I mean, that, for example, that we use in our facilities. Sometimes for some anatomical site, it might be helpful to create a VMAT PTV, which we will call optimization, by adding a little margin, like a 1 millimeter margin. This is done, for example, when the PTVs are very regular. So just to make sure that you don't jump from a structure to a structure, we're going to create a 1 millimeter margin just so you don't have sudden changes between a PTV in one slice or into the other slice. It will help you with the coverage in general. And then make sure if you create this ZVMAT PTV opt, which has a 1 millimeter margin, that's what normally it is. Make sure if when you create the rings, where we're going to go in a second how to create them, make sure that they go from this extract, not from the VMAT PTV. And I have an example, and this is normally we'll do it for lung cases. But for lung cases, sometimes the contours are very regular, and also you're constraining the lungs too much, so you know that you're going to be losing coverage. I mean, you want to definitely by the lung because of the constraining, the coverage is going to be not that great, but you want to make sure that you cover very well in the areas that you don't have that lung tissue interface. So that's why we create that 1 millimeter margin. So the PTV in here is red, and then you create the 1 millimeter margin of, that's your ZVMAT, PTV VMAT optimization. And in blue is the Rhine with a little margin, that structure that I'm going to talk in the next slides. Okay, so again, this is something that you're going to be learning while you're planning if it's really necessary. Most of the time it's not, except I think for lungs, from my experience, for our experience, it does help a little bit, but you know, it might not. So, but just keep in mind that that's something that is a trick that you can do. So we talk about, so all the structure that I talked so far is about PTV, just to focus on the PTV. Now we're going to be focused on the slide on structures beyond the PTVs. So, and I was talking a lot about these rings. So the rings are bands around the PTVs, and normally you create one ring per plan. And it's normally, what we normally do is the thickness is 1 centimeter, and we do it 3 millimeters away from the PTV. So if you have multiple PTVs, make it 3 millimeters away from the middle dose level PTV, and make the lower dose level PTV closer and the higher dose level PTV farther, because the farther, you know, it's going to get more dose, so you don't want to interfere with that. For example, you're going to start with a ring of 1 millimeter away from the PTVs, and then subtract the middle PTV with 3 millimeter, then subtract the higher PTV with 5 millimeters. So you make more space. And it follows the rule of thumb of the 5% per millimeter. For example, I have an example here of the prostate, and the PTV is in red. So we put 3 millimeter and we create this Rhine, which is, this is the Rhine that I was talking, 1 cm thick, and 3 millimeters away from the PTV. I said before that we normally create one ring, but some people use it because then you can use NTO to, you know, to take care of the doses away. But also sometimes, and that's planner dependent, we have many planners now, so they like to add a couple more of rings, just to actually make sure that to help conform the doses outside the PTV. If you do that, this again use the same concept, 1 centimeter, but then you don't leave spaces between them. Some people sometimes they leave a millimeter, but if you're careful with the objectives, you're not going to have any problem. So you can create as many as you want. For example, in this example, I put 2 more, and I said that they're extra, the magenta and the green. But then you need to be careful what is the dose that you're going to be using, the objective for those particular rings. Here is a case that I was explaining before when you have multiple PTV, you have to be very careful because, for example, we have a PTV 54, which is all these in orange. The colors again is the shadow here, orange. Then you have these PTVs in red, which is the 5940. And then you have in yellow the PTV 70. So basically, the ring number one for the 54, which is the lower ISO dose. You see how we took some margin from the from the ring. This is the ring of the 70, and which is here, and this is the ring for the 5940. So you need to leave margin because you know that in this area it's going to be there's going to be more dose because you try to give it more dose here. So you want to separate that ring 54 because if you put it here around the PTV 54, it's going to be conflicting with this ring. So make sure that you separate it. And again, here, I didn't put any margin for this, but remember that you can do 3mm margin for the first ring, first of all. And then we added 2 more rings here, but again, those are extras for the lower PTV if you think that is needed. So rines, as I said before, basically the rines, the concept of the rine, they are rings inside the PTV. This is the same concept, similar concept what I explained before as the edge contours. For example, in this lung case where the PTV is in red, then you can create this rind, which is 3mm ring or band. Let's not call it ring because it can be confusing, inside the PTV. And that actually will help you when the optimizer will struggle with the borders of the edges of the PTV. So basically, whatever I called before edge contours is what many people call rinds. So you will see that in different, that's what I wanted to put it here separately, but it's basically the similar concept to the edge contours. OR contours in general, we don't, for ORs, we don't do just Boolean operators in general for OR. You just create expanded contours, as I said before. And if they are overlapping with the PTV, we create those extra PTV, VMAT, and all those structures. We will know how hard to push and where to push on the ORs while optimizing by watching the shoulders of the PTV and the MAC doses of the rings. That's a very, and again, this is going to be, we're going to talk about this in the next talk, in the next talk on next Monday, how we look at that. Then I mentioned that we also have OR helping structures, we call dummies. So OR helping structures, in addition of the expanded OR structure that we said 3mm in general, these dummy structures, they might help the optimization algorithm to control the dose outside or inside the target. You need to be careful with this because a lot of people, they create a lot, you can fall into the habit to create all these hot spots or cold spots where you're optimizing, I want to take this hot spot, move it here, but it could be used, but the more you add is an indication that something in the initial contours, the ones that I explained before, or in the optimization is not correct. So it's best not to overuse them, but to improve the technique instead. So basically, I want to put it because many institutions, they use them, maybe a couple or a couple of hotspot or dummy structure, maybe an area that you want to decrease those outside the target. It is okay, but use it with caution. For example, I have an example here that the PTV is the red. You have the brainstem overlapping, the chiasm is very close with the structure, with the extended, the cochleas are very close. So, but for this case, for example, the physician, for this particular case, was very interested to limit as much as possible the dose between in this area, in the middle of the brain, that there was no target. So the planner here created this dummy meat structure Again, you can create it, you can use it with caution. You need to make sure that these structures is very well, the objectives is very well thought when you're in the optimization process. But it might help because you're going to be doing optimization to your brainstem and to your chiasm. Also, you need to make sure that it should be in sync with what you're doing with this middle structure. So it is useful, but my advice, use it with caution. So basically then the last thing that I want to, the last thing, the structures, again, these are also optional structures that you can create when a structure is overlapping with a PTV. Remember that I explained with the parotid, the case that we create those VMAT shells, VMAT OR. That's a good technique, but also sometimes, for example, in this case, you can, for example, this is prostate case that you know that most of the time the bladder is overlapping with the PTV. Sometimes just to help the area of overlap to get, because you're going to be constraining to the bladder to a maximum dose or some volume constraint. So you want to make sure, yeah, you constrain the whole bladder with the margin if you want, but also you don't want to lose too much cover in this overlap area. So that's why we create the Z bladder, not PTV, which is in blue. So from here, like excluding the PTV. And then we create the Z bladder and PTV, which is basically the overlap region, which is in Zion. And we're going to giving, okay, I'm going to be giving this structure, okay, some objective, but putting here some objectives just to say, don't forget to cover here. I mean, as much as you can. Of course, it's going to be a little bit of sparing, though the isodoses because of the bladder constraint, but sometimes it helps. Again, these, you don't have to do it if you created those VMAT shell structures that I told you, or VMAT ORs. But sometimes it's another technique and is very well used in many places. So as a summary, and I think we're good on time, basically make sure, remember that I told you OR contours, everything needs to be perfect, but imperfect can be when it's far away. Important to create your own contour naming convention. Empower your doctors when you're doing fusions to make sure they know how to tweak the registration if they need to do modification. And carefully inspect the contours, especially if you're using auto segmentation tools. Then we talk a lot about all these additional structures we call optimization only structures, with basically the main focus and the main purpose of this is just to control the dose distribution during the optimization, and they're defined by the planners. We use that dose fall-off concept to create contours. And very important, no conflicting argument. That's what is very important when you create the contours, equals to a perfect optimization the very first time. Most probably you will need to go back and forth to create more contours, because if you create the right contours with the thought, you're going to be doing your optimization in the first try and achieve everything on the first try. And again, all the more details of this presentation will be found in this guideline document that I'm gonna give it to you. And just remember that perfect contours lead to perfect plans. So that's basically, that's what is so important to talk about that. So thank you very much for your attention. I think we're good on time. So we have 5 minutes. There might be questions and I'm very happy to answer. And if you don't have any question now, this is my email address. You can always send me an email with anything. And again, these slides are going to be available to you, plus the other documents that I said that they're going to be available to you.
Great, thank you so much. Yeah, if anybody has any questions, feel free to unmute yourself and ask. We do have one question in the chat, and that was, how would you compare the results of the ring to normal tissue objectives? Yes. Mm-hmm.
Yes, actually, this is a good question, because that's what I was, that's what in general, we advise to create only one ring, the one very close to the PTV and no more, because then probably you're going to be competing with the MTO. But For example, we've done a lot of studies at work that some planners, the planners that they like to create many rings, and they have a good idea how to do the doses, they don't use NTO, because then you're going to be controlling the doses outside with the ring. But you have to be, I think you have to be very experienced to that. So my advice is just to create one ring and then use the NTO. And then you know that the NTO you can keep changing while you're optimizing and see what's going on outside your target. But if you create a lot of ring and you're also using the NTO, that's not a good combination, because then you're going to be competing with the NTO. So personally, I like the NTO, but I know that there is people that they don't like the NTO, because sometimes, the NTO, you need to be very careful how you define the, when you start to, the dose fall off and all that, and it works for some things, it doesn't work for other plants, especially when, for example, when it's a prostate case, which the contour is very round in the middle, NTO probably is really good. But for a head and neck case that you have tons of structures to worry about, maybe NTO is a little more challenging, but don't use both, a lot of rings and NTO, just use one another. And that's preference.
Okay.
But NTO, I mean, NTO works really nice too. So I don't want to.
Okay. Any further questions that anybody has?
Yeah, hello?
Hello?
Yeah. In the case of pharynx, where the oncologists want to cover the stethoscope, or where the tumor is outside the body, some suggest that you should crop off from to the body, but the oncologist insists that, oh, you want to cover some space. Will that give you a good plan?
Yeah, that's a good question. And actually, yes, you need, I mean, you know that you need to crop the PTVs that they go outside the body, because then your algorithm will, will be really confused if you have something outside the body. And normally, for example, what we do in those cases, we normally crop, I mean, two things, if the GTV is very close to the surface, most probably the physician will ask for a very good coverage, even up to the skin. In that case, you might need to use a bolus to bring the dose up to the skin. But always the PTV, you might need to crop it a little bit outside of the, for example, let's say if you're using 6 MB, that you know the build-up region is 5 millimeter, and you're using a 3 millimeter bolus, so the PTV VMAT, you should create it with the 2 millimeters crop. So basically gives you the 5 millimeter build-up that is going to be done by your 3 millimeter border plus the 2 millimeter skin area. And then you know that your coverage is going to be very good. But you should crop it, because if not, your coverage is not going to, I mean, the optimization would be okay. Is that exactly what you meant with your question, or?
Thank you. Yes, I love it.
Yes. But that's one thing when I tell you to basically verify the physician's contour. It's very easy when, to have contours like all over the place, especially when they create margin, they go outside the body. But it's our job to make sure that we bring them to the body. And if, for example, if it's a case that you don't need a bolus because GTV is inside, they are not very, let's say for the brain, that the PTV expansion went outside the body, you just crop it to the border of the body with no margin and everything. Yes. Any other question? Oh. And again, as I said, if you have any more question or you want to talk more, please feel free to send me an email anytime from now on. I will be happy to answer anything.
Great. Well, thank you so much for this wonderful talk. Very informative. We much appreciate it. And we look forward to more lectures from you as well. It looks like the next scheduled lecture is on Monday at the same time, which I believe you're hosting as well.
Yes, and it's about the process, VMAT planning process, or IMRT VMAT. Yeah.
Perfect. Great. Well, thank you so much. And as previously mentioned, we'll be sending out the slides. And if anybody logged in late, or if you have any colleagues who missed this session, we'll also have a link that goes out to the recording. So thank you everyone for joining.